Yes.
Checks delivered.
All good. Well, good morning, and I'll invite us to take our seats this morning. I'm Bill McNeese. I'm president of the Wood Library Museum of Anesthesiology. Thanks to all for joining us this morning for the Lewis H. Wright Memorial Lecture. This session begins a series of abstracts, panels, lectures, and other events related to the history of anesthesiology over the next several days. We hope you'll be able to join us for many of those events. I'll begin this morning's program with a brief introduction of Kathryn McGoldrick. Now, it's brief not because there's not much to say, but because you're going to hear more about her shortly. So, with that, Dr. McGoldrick has served the Wood Library Museum for many years, since 1994, in a number of different roles. That includes a variety of services, both to the WLM and to the profession. In addition to her many roles, we're fortunate that she continues to find time to serve the WLM as chair of the WLM Distinguished Service Award Committee. And it's in this role that I'll ask her to come to the podium to introduce the 2018 WLM DSA recipient and present their certificate.
Thank you, Dr. McNeese. It's with great enthusiasm that the Wood Library honors Dr. Selma Harrison-Commies as its 2018 recipient of the Distinguished Service Award. Selma's service to the Wood Library goes back to 1984, so almost 35 years, when she served her first 9-year term as a trustee of the Wood Library Museum. She then came back for an encore in 2006, serving another 9-year term and serving as vice president of the board from 2014 to 2015. And during those 35 years of service, she served on multiple committees and was instrumental in advancing several initiatives of the library. However, Selma has also played a major role on the broader stage of anesthesia. She has risen to the ranks of clinical professor at UCLA, where she's mentored an enormous number of residents, particularly women residents. She's educated us about the women pioneers in anesthesiology: Mary Botsford, Julia Arrowwood, Margot Deming, Isabella Erb. And she was very instrumental in the 1990s getting a Great American commemorative stamp for Virginia Apgar of Apgar score fame. And in more recent years, Selma has called attention to the anesthetic implications of the post-polio syndrome. I could go on, but I just want to close by saying for more than 30 years, Selma has been a cherished friend and a very special role model. All of us at the Wood Library admire and love Selma for her commitment to excellence, to her integrity, and for her perseverance and, yes, courage. So it is a great honor for me to bestow the Distinguished Service Award on my dear friend Selma Harrison-Commies.
Thank you, Dr. McGoldrick. I'm very, very thrilled and still very stunned. So many people have helped me along the way to this award. I started a list, and it became very, very long, too long to do definitive statements for each person. And I'd like to just say a group thank you to everyone who has helped me along the way. You've been very important, and I'm very, very grateful. I'd like to acknowledge my family, who's been very much a part of Wood Library Adventures. My husband, Bob, children, Keith and Kathy, and my brothers and other family members, many of whom are here today. I'm very thankful to you all, and very, very grateful to the Wood Library for this award. Thank you.
I'll next ask Susan Vassallo to approach the podium. Dr. Vassallo has also served the world of anesthesiology and the WLM for many years in a number of roles, including service as the president of the WLM from 2011 to 2015. She continues to be active in the work of several of the committees of the WLM, including service as chair of the Lewis H. Wright Memorial Lecture Committee. And it's in that role that Dr. Vassallo now comes to the podium to introduce the 2018 Lewis H. Wright Memorial Lecturer. Dr. Vassallo.
Thank you. The Lewis H. Wright Memorial Lecture is sponsored annually by the Wood Library Museum of Anesthesiology, henceforth the WLM, and honors its namesake, who is a pioneer in American anesthesiology. Dr. Wright was committed to enhancing anesthesiology as a clinical science and as an advanced medical specialty. He was a founding member of the Anesthesia Library and then was president emeritus of the Wood Library Museum. In 1973, the New York State Society of Anesthesiologists endowed this lectureship to honor Dr. Wright, who died the following year. Let's see if we can do this. Not advancing. Well, I had an image of Dr. Wright along with Paul Wood. Here, let me see if I can get it. There we go. There's Paul Wood on the right with Dr. Wright here. So this year's 2018 Wright Lecture, Kathryn E. McGoldrick, MD, Professor and Chairman Emerita of New York Medical College and a current member of CLEAR, which is the Clinical Learning Environment Review, which is a division of the ACGME, Accreditation Council of Graduate Medical Education. The title of Dr. McGoldrick's lecture is Airway Management Through the Ages. In this lecture, Dr. McGoldrick will highlight the discoveries, procedures, and publications which contributed to the development of expertise in airway management. She'll trace the history of tracheotomy from antiquity to the present, and she will discuss airway management from the 1840s to the 20th century. On the behalf of the Wood Library Museum of Anesthesiology, we thank Dr. McGoldrick for her commitment to clinical anesthesia, academic medicine, and scholarly research. We will be reminded of the accomplishments which brought our specialty recognition and respect. Thank you, Kathy.
Well, good morning and welcome. I'd like to thank Dr. Vassallo and her committee for inviting me to give this lecture in honor of the very distinguished anesthesiologist Lewis Wright, who worked indefatigably to introduce curare into clinical practice. The kindness and generosity of the invitation are obvious. However, I think the wisdom of the invitation will remain to be seen. The great surgeon Friedrich Trendelenburg said, "Today always rests on the foundations of yesterday, and it is a matter of the highest interest to trace the gradual development." And I do think history is a wonderful way for us to get a little insight into human understanding. And, when we think about it, contingency, context, and serendipity are always at play in history. And progress sometimes happens with glacial speed. And this was particularly true during the early years of our specialty after 1846, when Morton did the first public demonstration of surgical anesthesia. And we'll also see that during those early years of our specialty, surgeons played a major role in advancing the safety of anesthesia. One of my favorite quotes about history is by the eminent historian David McCullough, who said, "To me, history is an enlargement of the experience of being alive, just the way literature or art or music is." During this lecture, I'd like to trace the role of tracheotomy from antiquity to the present and summarize the effect of the zeitgeist, or the cultural sense of the time, on the application of the procedure. We'd also like to discuss the primitive approaches to airway management that characterized that 60-year period from 1846 to the early 20th century. We'll also describe the combination of events, influences, and individuals, some of them very colorful, that enabled anesthesiology to progress from a craft to a profession characterized by expertise in airway management. And finally, I'd like to refract progress in airway management and resuscitation through the prism of contemporary accomplishments in other areas of medicine and society. I have no relevant financial relationships to disclose, unfortunately. However, having a relevant financial relationship is on my bucket list. Now, we're going to be discussing the three basic routes for airway management: extraglottic or supraglottic, glottic, and infraglottic. And I'm sure all of you in the audience are familiar with the wonderful series of articles that were published by Adrian Matioc in Anesthesiology over the last few years. And he characterizes the eras of basic airway management as the pre-anesthetic era from 1700 to 1846, the artisanal anesthetic era from 1846 to 1904, and then the progressive era from 1904 to 1960. And we'll basically be following this timeline during the course of the lecture, with the exception that for the pre-anesthetic area, we're going to go way back before 1700. We're going to go back millennia. And I think it's important to emphasize that before we had surgical anesthesia, we had resuscitation. And resuscitation, airway management with regard to resuscitation took many forms: tracheotomy, mouth to mouth, which the midwives did in the 18th century, and then the bellows. So it's very important, I think, to appreciate that intubation of the trachea for resuscitation is 3 centuries older than for anesthesia. And Vesalius, in around 1543, passed a tube into an animal trachea, and he delivered artificial respiration with air. And he described this in his multi-volume Fabric of the Human Body. And we see here an illustration from Vesalius's Fabric of the Human Body. And it shows a preliminary tracheotomy that's being done on an animal prior to inserting a reed tube. So they use very primitive structures to insert into the airway. And Vesalius, like many great scientists, was very observant. And he noticed that if the lungs remained collapsed, that the pulsations of the animal's heart became ondosis, formicans, and vermicularis. In other words, he was describing the worm-like sac that we see when a heart is in ventricular fibrillation. Very observant, and will emphasize the role that observation plays in advancing science throughout this lecture. And the great physician William Osler said, "The whole art of medicine is an observation, but to educate the eye to see takes time." And we'll see a lot about that educated eye throughout this lecture. Now, what do we know about tracheotomy in ancient times? We think that it goes back about 5,000 years. In about 3100 BC, there's suggestive evidence through some hieroglyph slabs that tracheotomy was performed in Egypt. And then from about 2000 to 1000 BC, sacred Hindu books allude to opening the airway. And then in the 8th century BC, Homer described the treatment of choking by incising the trachea. And then about 100 years BC, Asclepiades of Bithynia was the first surgeon to perform an elective tracheotomy. So tracheotomy goes back a long time. But then in the Dark Ages, tracheotomy fell into disrepute. And from about 500 to 1000 DC, a tracheotomy was considered a barbaric procedure that no responsible physician would perform. And in fact, in the 13th century, tracheotomy was considered semi-slaughter, and the great Dante indicated that it was appropriate for sinners in the depths of hell. Now, to briefly compress the progress of tracheotomy, we know that in 1546, the first documented case of a successful tracheotomy used to treat a patient on the verge of death from an abscess in the windpipe was performed in Italy. And then in 1610, we know that tracheotomy was used to manage diphtheria. And we see over the course of time that the tubes or the instruments inserted into the incised trachea progressed from reeds and quills or feathers to a variety of mostly metal tubes of various shapes. And then in the early 20th century, the great surgeon and endoscopist Chevalier Jackson recommended a vertical incision into the second and third tracheal ring, so more like the tracheotomies that we're familiar with today. And the indications for tracheotomy have, of course, expanded over the centuries. At first, tracheotomy was used to overcome that classic fixed obstruction of the upper airway, and then it was used to manage a more fluid obstruction of the lower airways. Then it provided a permanent replacement for larynxes lost to cancer. And then, of course, since the 1950s, tracheotomy has been used to facilitate prolonged mechanical ventilation. Now, with regard to other methods of resuscitation in the airway, we know that the midwives successfully used mouth-to-mouth ventilation to treat asphyxia neonatorum in the 18th century. Physicians were too proud to do that. They considered mouth-to-mouth ventilation vulgar. So I think it's really wonderful to think of all the little babies that those midwives saved because they weren't too proud to do mouth-to-mouth ventilation. And then drowning victims were very common in the 18th century. And mouth-to-mouth ventilation was gradually replaced by instrumental positive pressure ventilation, which was generated by bellows. And I'll show you a picture of bellows device shortly. But interestingly, pulmonary ventilation played a very secondary role to external and internal interventions. And some of those interventions were heating the victim, applying friction, touching, bleeding, and then even internal interventions such as, God knows why, rectal insufflation. But the important point is that little attention was paid to relief of upper airway obstruction. They were more interested in heating up the victim and touching the victim than they were to maintaining airway patency. Now, to switch a little bit from resuscitation to surgical anesthesia, I love this painting by Robert Hinckley, The First Operation with Ether. I think it's very magisterial, and it really imparts the sense that this was a transformative event in medical history, the dawn of surgical anesthesia. And in this picture, we see William Thomas Green Morton, a dentist, administering anesthesia to the patient, Edward Gilbert Abbott, and of course, John Collins Warren was the surgeon. However, magisterial as this painting is, it every time I look at it, it reminds me of some of the rather unsavory characters that were involved in the ether controversy. Morton himself was no saint. He really spent his life seeking fame for discovering ether, and he also wanted some rather munificent monetary reimbursement for his efforts. And he was obsessed with the idea of getting credit for introducing surgical anesthesia. He was the first to successfully publicly demonstrate, and he timely wrote it up. But there is a great deal of controversy surrounding who really should get credit, although generally it's agreed that it probably should be Morton. Other contenders for the role were Charles Jackson, who was a physician, a chemist. He was really a polymath. He was also a geologist and really brilliant man, but he was consumed with getting credit. And then, of course, there was Horace Wells, a dentist from Hartford, who became addicted to chloroform threw sulfuric acid on some prostitutes walking along the street in Hartford, was arrested, and committed suicide during his incarceration in prison by cutting his femoral artery with a razor. So in refreshing contrast to those rather motley crew of folks was Crawford Long. And we know that Crawford Long, a physician in Georgia, administered anesthesia to his patients, general anesthesia to his patients, as early as 1842, 4 years before Morton's successful demonstration. But Crawford Long didn't write about it until 1849. So he never really got the credit that he deserved. But it didn't bother him because he was a very decent person who considered being a physician a ministry from God, which were his words. And he never cared about getting credit for being first. Now, I think it's important with Hinckley's portrait there to mention that it isn't really historically accurate. He painted it several decades after Morton's demonstration, and he painted into history people who weren't there. But the picture does very nicely depict the years before antiseptic and aseptic surgery occurred. You'll notice that in that picture, gentlemen were wearing their street clothes and they didn't have on masks or rubber gloves. And in fact, sterile surgery was not achieved at Massachusetts General Hospital until the 1880s. Now, what factors led to the discovery of anesthesia, the quote, discovery of anesthesia? Well, back in the 13th century, we had somniferous sponges. Then in 1540, Valerius Cordus synthesized ether from sulfuric acid and ethyl alcohol. In the 17th century, William Harvey described the systemic circulation. And then in the 18th century, Joseph Priestley identified new gases which were used for medicinal purposes by the Bristol Pneumatic Institute. And Priestley actually developed nitrous oxide in 1772. Now, this kind of begs the question, does culture drive innovation? And other factors leading to the discovery were that Sir Humphrey Davy in 1800 suggested possible anesthetic qualities of nitrous oxide. And recall that Priestley developed it in 1772. So there was a little gap of time there before Davy appreciated the potential anesthetic qualities of nitrous oxide. And then in the 1820s, Henry Hill Hickman, a young surgeon, opposed all forms of human suffering. And then from around 1800 to 1850, we have the Romantic poets who were very concerned with the rights of the individual and didn't see that pain and suffering were necessarily good things. So we think that the lag time from all of these pre-surgical anesthesia events until October 16th, 1846, arguably were related to societal attitudes that held that blunting of pain was morally wrong. And I think it's important to point out that history is not a continuum. Anesthesia isn't the only field where there were gaps and delays before real progress was made. And so some other examples of historical scotoma are that in the 3rd century BC, Aristarchus proposed a heliocentric solar system 1,400 years before Copernicus. Who knew? Archimedes invented calculus 2,000 years before Newton and Leibniz. And John Mayow in the 1670s all but discovered oxygen a century before Seeley and Priestley. But his work was obscured by the phlogiston theory until Lavoisier disproved it in the 1780s. Now, does anybody know who this rather formidable-looking gentleman is? Yes, very good. George Bernard Shaw, which I am very proud to point out. He was the first of 4, as yet, Irish writers to win the Nobel Prize for Literature. The ones who came after Shaw were, of course, William Butler Yeats, Samuel Beckett, and more recently, Seamus Heaney. Well, in 1906, George Bernard Shaw wrote The Doctor's Dilemma. So this was 60 years after Morton's demonstration of ether. And as you know, The Doctor's Dilemma is a rather scathing satire of the medical profession. And there's a very interesting theory of history that the narrator has, the narrator being Sir Patrick or Paddy Cullen. And he is congratulating his friend, Colenso Ridgeon, who's just been knighted for discovering a new treatment for tuberculosis. And Paddy says to Sir Colenso Ridgeon, "But your discovery is not new. It's only inoculation. My father practiced inoculation until it was made criminal in 1840. So Shaw's theory was that his ideas get cycled and recycled, and that there's really nothing new under the sun. They wax, fashions wax and wane. Now, Paddy was quite the philosopher, and he had some more wisdom. He was telling his friend, Sir Dr. Ridgeon, he was describing Walpole. And Walpole is a rather bombastic surgeon in the book who is not the sharpest knife in the drawer, so to speak. And he thought that all of mankind's ills could be cured by cutting out the nuciform sac. So with that as background, Paddy says, Walpole's only one of your chloroform surgeons. In my early days, you made your man drunk, and the porters and students held him down, and you had to set your teeth and finish the job fast. Now you work at your ease, and the pain doesn't come until afterwards, when you've taken your check and rolled up your bag and left the house. I tell you, Collie, chloroform has done a lot of mischief. It's enabled every fool to be a surgeon. Now, we'll go back about 55 years, to John Snow, who was really the first professional anesthetist. He was a brilliant man. He studied 16 different gases and made a lot of scientific contributions, including recognizing the inverse relationship between blood solubility and partial pressure. He was one of the first to document anesthetic mortality and discouraged the use of such agents as amylene and other agents that he thought were harmful. He was also an epidemiologist and gained recognition for what he did to end the cholera epidemic by identifying the Broad Street pump in 1854 as the source of the epidemic. He had so many accomplishments, developed a face mask, administered chloroform to Queen Victoria, and he was the first in the 1850s to produce endotracheal anesthesia in an animal via tracheotomy with a wide-bore tube. So he incised the trachea of an animal, inserted a tube, and introduced anesthesia in that setting. And then about 15 years after, again, our surgeon friend, Friedrich Trendelenburg, was the first to use Snow's procedure on man. And he passed a wide-bore tube with an inflatable cuff. And it was really quite remarkable that he was able to fashion an inflatable cuff in that era, as we'll see later in the lecture. But endotracheal anesthesia, as we know it, didn't occur until another surgeon, William McEwen, in 1880, inserted a metal tube into the trachea via the mouth, and he did it guided by touch. And then he had an uncuffed tube, and he packed off the larynx and added chloroform after that. So this, again, to emphasize, this was endotracheal anesthesia as we know it, not through an incision in the trachea, but through a less invasive approach. Well, we've talked about what was happening in the very beginnings of surgical anesthesia. Let's place it in context and see what else was going on in the world and in science at the time in the mid-19th century. Well, we know that they didn't have cars in those days, and in mid-19th century Manhattan, manure was ubiquitous, and there was no municipal sewer systems. Epidemics were rampant. The horses just roamed the streets of Manhattan as a means of transportation. And I know this is too much information, but I did read that the typical horse would dump 15 pounds of manure a day into the streets. That maybe the good old days weren't so good. And in 1847, Semmelweis made a great leap forward when he postulated invisible infective particles were being transferred to parturients, and he advocated washing one's hands with chlorine solution. And then in 1861, Pasteur showed that sour milk caused by bacteria can be prevented by heat sterilization. And then about 15 years later, again a gap, Pasteur went on to suggest that heat sterilization of surgical instruments might indeed be helpful. Shortly after that, Koch identified the tubercle bacillus and then cholera. So we're starting to see progression with the germ theory of disease. And in the late 1800s, Lister introduced antisepsis to surgery with dilute carbolic acid. And then in 1896, the great surgeon Halsted introduced sterile rubber gloves and scrupulous asepsis. And, you know, Halsted was a brilliant surgeon and did many innovative operations and contributed a lot. But as is now well known, he suffered with addiction. He struggled with it most of his life. And initially, he was doing research with cocaine, became addicted to cocaine. And in those days, cocaine addiction was treated with morphine. And poor Halsted then also developed an addiction to morphine. And despite all that, he was able to contribute over many, many years to advanced surgery. There's a wonderful book that I'd like to recommend to you. It's by a plastic surgeon, Gerald Imber. He's from Cornell, and it's called Genius on the Edge, and it's a wonderful tribute to Halsted, but it's also a wonderful tribute to William Welch, Dr. William Welch, who was the dean of Johns Hopkins at the time. When Halsted was at Hopkins, they had these four magnificent physicians, William Welch, a pathologist, Halsted, of course, William Osler, and Dr. Kelly. And they are depicted in that wonderful painting by John Singer Sargent, sort of the big four at Hopkins. And Welch was just an extraordinary friend to Halsted. He did, I think, everything that was humanly possible to support Halsted and see that his genius could be used to advantage, despite all the struggles that Halsted had with his demons. Joseph Lister was a medical student at University College in London when that great surgeon showman, Robert Liston, announced to the med students in 1846, right after Morton had done a successful demonstration, "Gentlemen, we are going to try a Yankee Dodge for making men insensible." And that's the origin of the term, the Yankee Dodge, to describe ether anesthesia. Before Lister, however, surgeons dared only to excise limbs, reset bones, and hack off, excise lumps, reset bones, and hack off limbs, in other words, amputations, and lumps and bumps. Innards were left to apothecaries because the risk of infection was just so rampant that the surgeons dared not go there. And Lister was subsequently acknowledged as the father of modern surgery. And I think it's interesting to reflect here that much as surgeons helped advance anesthesia in the early days, bacteriologists really helped to advance surgery in the early days. Now, we have here Joseph O'Dwyer, who was a Irish-American surgeon who worked in upstate New York. And he devised a modified Fell-O'Dwyer apparatus that I'll show you a picture of in a second. He did that in 1887. He developed a series of metal laryngeal tubes that could be inserted blindly into diphtheria patients. And he devised a long intubation cannula that was fitted with a conical tip. And it had an external end with two branches, one that allowed air ingress from the bellows and one that allowed egress. And you see it demonstrated here. You see the bellows canister, the long cannula, and the conical tube, and the ingress-egress outlets there. Now, we talked about management of drowning patients in the 18th century. Let's see what happened to those patients in the 19th century. How were they treated? Well, instrument-driven positive pressure ventilation, such as those bellows, was replaced by manual negative pressure techniques. And however, still, those simulation methods, such as warming, tickling, rubbing, applying stimulant vapors, took precedence over ventilating the lungs and maintaining a patent airway. That need for a continuous, unobstructed upper airway during both inspiration and expiration still remained unrecognized. And it's interesting to note that these manual negative pressure techniques for resuscitation remained unchallenged until the 1950s. Well, those methods were replaced by reproducing respiratory movements by manipulating the victim's upper extremities and thorax, the back pressure arm lift technique. And Sylvester in London described a technique for supine victims. Schaefer, also in London, described it for prone victims. And then Nielsen described the back pressure arm lift techniques for prone victims. Now, during those times, our attempts to relieve upper airway obstruction were quite primitive from 1846 on to the early 20th century, the early 1900s. There was chin lift, head extension, jaw thrust. Pincers were used to pull the tongue forward to lift the epiglottis. But the oropharyngeal airway, that really rather simple primitive device, was not introduced until the early 1900s. So what were those salient features of the artisanal anesthetic era? Well, there was head extension and mandibular advancement. Spontaneous ventilation was the mode in anesthesia, surgical anesthesia. We used manual ventilation and negative pressure ventilation for resuscitation. During anesthesia, there was very poor muscle relaxation and pain control, especially postoperatively. Nausea, vomiting were common, pneumonia from aspiration, very common, and shock and death were also not unusual in primitive anesthesia. And importantly, many people who administered anesthesia in the early days, the first 50 or 60 years of the specialty, were non-specialized providers. Well, what were while we were struggling with trying to maintain a patent airway, what were the surgeons doing in the late 19th century? Well, we've mentioned asepsis and antisepsis. They also paid a great deal more attention to intraoperative hemostasis, and they appreciated now the pathophysiologic basis of surgical disease. Now, what about other branches of science at the end of the century, the fin de siècle science? Well, in 1900, Max Planck described the quantum theory. Einstein's theories of special and general relativity were developed during that era. Niels Bohr described electrons and complementarity. The Curies described radioactivity that emanated from radium and polonium. Röntgen had his X-rays. Landsteiner developed blood groups. And Paul Ehrlich developed the magic bullet for syphilis. And there was also, around the turn of the century, a concurrent artistic explosion with regard to revolutionizing compositional technique. We can think of the works of Stravinsky, Sibelius, Bartók, Holst. There was a lot of intellectual foment going on at that time. Which brings us to Sir Frederick William Hewitt, a great anesthetist in England. And in 1890, using his powers of observation, he did a classic summary of the causes and management of airway obstruction. But it was almost 20 years from his observing what caused airway obstruction to his designing a forerunner of many oropharyngeal airways. However, the prototypical airway was not Hewitt's most notable achievement. And before I show you a picture of the airway, I just want to emphasize what Hewitt concluded were high-risk patients. He talked about edentulous patients, those with facial hair, a short neck, obesity, and large tonsils, receding jaw chin, nasal obstruction. And he came to appreciate, through his powers of observation, again, airway obstruction could occur anywhere between the nose and the epiglottis, and it could occur during inspiration, expiration, or both. And mandibular advancement addressed both the tongue and epiglottic issues by its effect on the glossoepiglottic ligament. And this is Hewitt's first airway. It's metal, and you can see the sort of conical bite block at the end of it. Can you imagine what that did to dentition in the early 1900s? Fortunately, there were evolutions of that metal airway, and in 1933, Goodell designed a non-traumatic rubber airway, and then Berman in 1951 designed an open-sided polyethylene disposable airway. Big improvement over these early airways. Now, we mentioned that important as Hewitt's oral pharyngeal airway was, it wasn't his most important contribution. He invented the first practical machine for delivering nitrous oxide and oxygen in fixed proportions. During those times, it was very common for anesthetists to administer 100% nitrous oxide to patients, who, of course, became quite cyanotic. Hewitt also developed or improved a chloroform inhaler. He improved designs of dental mouth props. He redesigned Clover's inhaler. He produced two brilliant classic anesthesia texts, and he was a founding member of the Society of Anesthetists in London. He was appointed anesthetist to His Majesty, and shortly before Edward VII was to be crowned, he developed appendicitis, and Hewitt administered his anesthetic, which was probably very challenging because Edward VII was quite corpulent, had a beard, and had a very receding chin. It paid to have friends in high places because then Hewitt was appointed to the Royal Victorian Order, and he was subsequently knighted about 9 years later. He worked very hard to persuade the government to draft a bill, which was never passed because of all the preliminary events to World War I, to ban administration of anesthetics by unqualified individuals. And this slide just depicts Hewitt's device for adding oxygen to anesthetic apparatus. And you can see that that was in 1892 and 1893, on that side of the pond, whereas in America it was a bit after that before we incorporated oxygen into some of our anesthetic devices. And I think we really cringe to think that cyanosis was very much part of the early anesthetic experience. And it was supported by many false beliefs, some of which was the mistaken concept that anesthetized patients could better tolerate hypoxia. And as recently as the 1920s, hypoxia was still accepted, but there was a distinction made between suboxygenation with a clear airway versus obstruction-induced cyanosis. And McKesson, of McKesson equipment fame, bemoaned the fact that although dentists were not afraid of cyanosis, it was a stumbling block for ether and chloroform-trained anesthetists and surgeons. Well, it's probably hard for us to imagine that laryngoscopes weren't always available, but in the 19th century, doctors used natural light to view the larynx. Benjamin Guy Babington in 1829 used a spatula and mirror, probably not unlike the device that dentists use today. And then in the late 1800s, in 1895, the surgeon Alfred Kirstein designed the first direct laryngoscope, and shortly thereafter, that very distinguished surgeon, Chevalier Jackson, performed his first bronchoscopy. Well, we're now into the early 20th century, the early 1900s, which really begins the redemptive arc of modern anesthesia history. So we're entering the progressive era from 1904 to 1960. And what happened during that time span was there was a transfer of leadership from surgeons to anesthesiologists in terms of delivering surgical anesthesia. Academic departments were developed, journals were created, and professional organizations were formed. There was a great deal of growth in both local and regional anesthesia. Suction was introduced, and we finally came to appreciate that the effectiveness of basic airway management largely determined survival. Now, we have here the wonderful Sir Ivan McGill, another Irishman who was born in County Antrim. He graduated from Queen's College, Belfast. He never really sought to become an anesthesiologist, but after World War I, the First World War, he went to work in Queen's Hospital for facial and jaw injuries in Kent. And there he had the opportunity to work with Stanley Rowbotham to administer anesthetics and with the very distinguished surgeon Harold Gillies. And I think this is a prime example of how perhaps the only good thing that can be said about war is that it frequently leads to advances in medicine and surgery. And up until McGill and Rowbotham started caring for these very severely injured World War I veterans, the primary mode of anesthetizing them was to use rectal oil ether. And fortunately, McGill was very creative. He thought like an engineer, and he made some great strides in terms of anesthetizing these patients. He designed his McGill forceps. He developed blind nasotracheal intubation. Again, this was a result of his keen powers of observation. He noticed that when he was trying to introduce catheters into the trachea for insufflation anesthesia, that frequently it fell right in without any sort of instrument to advance it. And he noticed that was most apt to occur when the head was in the so-called sniffing position, which he defined as the position one's head is in when you're either sniffing the morning air or draining a pint of beer. He also devised a laryngoscope. It was initially a rigid laryngoscope. He developed thoracic anesthesia at Brompton Hospital. He devised endotracheal tubes and just made marvelous contributions, and in 1960 was knighted. And this is his eminent colleague, Stanley Rowbotham. Another very distinguished anesthetist of that era was Sir Robert Reynolds Mackintosh. And he had a very pathetic early life. He I think, was born in New Zealand, wandered through South America, and finally ended up in Europe. And he initially started out giving dental anesthesia. His experience during the Spanish Civil War in 1936 led him to develop a compressed gas machine that could be used in the battlefield. And he was a very sociable person, similar to McGill. And he formed a friendship with William Morris of Morris Motor Company. They played golf together. And Morris was also Viscount Nuffield, very wealthy man, and he announced to Mackintosh one day that he was going to donate £2 million to Oxford to develop chairs in medicine, surgery, and obstetrics and gynecology. And Mackintosh said, "What? Anesthesia's getting left out again?" So Lord Nuffield reconsidered, and he established a chair in anesthesia as well. And in 1937, Mackintosh was named professor at the Nuffield Department of Anesthetics at Oxford. In 1943, he serendipitously discovered his curved blade laryngoscope. And again, it was in the context of very keen powers of observation. McIntosh was anesthetizing a patient for tonsillectomy, and the surgeon put in a size too large Boyle-Davis mouth gag. And lo and behold, when the gag was opened, there was a beautiful view of the epiglottis and the vallecula. And McIntosh then, after he left the theater, he had a talented technician named Richard Salt, described what he wanted to be devised. Salt, within hours, created a version from that Boyle-Davis mouth gag of a blade that he then attached to a laryngoscope handle, and that was how we have our McIntosh blade. McIntosh was also a very straight shooter. He was noted for his intellectual honesty. And in those days, apparently, it was not uncommon for surgeons and anesthesiologists to ascribe interoperative misadventures and death to status lymphaticus. And McIntosh said that's nonsense. It's hypoxia, pure and simple. And that was a very important acknowledgement. He also championed regional anesthesia in the 1940s and even in the 1950s after the Woolley and Rowe debacle. And he was knighted in 1953. And here we have a picture of Sir Robert and Lady McIntosh and his beloved dog, Oscar. Now, McGill and McIntosh had a lot in common. They were gifted leaders who were team players. They were committed to developing anesthesia as a specialty. They appreciated the fruits of networking. They networked very well with one another, and McIntosh in particular networked with Ralph Waters in America. They were both innovative, and they owed a lot to chance and to their powers of observation. And importantly, they were accomplished athletes who were blessed with impressive longevity. They both lived into their 90s. I believe McGill died in his 98th year. This is in contrast to John Snow, who, of course, died at age 45. And I think it's really tempting to think of what Snow might have accomplished had he been granted the blessing of a longer life. Well, what can we say about medical and surgical advances during the first half of the 19th century as anesthesiologists were finally starting to get a handle on maintaining airway patency? So what were the surgeons and other colleagues doing? Well, in pharmacology, anti-inflammatory drugs were introduced, anticoagulants, insulin, vitamins, antibiotics, psychotropic agents, and vaccines. New specialties were developed: infectious disease specialists, ophthalmology, oncology, endocrinology, cardiothoracic, pediatric, orthopedic, plastic, and neurosurgical subspecialties. And finally, surgeons were able to progress from simple incision repair, amputation, to reconstruction and transplantation. And what about resuscitation in the 20th century? Well, in 1929, the Drinker-Collins tank respirator was introduced, and it operated by having by triggering inspiration through expanding the thoracic cage with external intermittent negative pressure. And then expiration was passive. And this was really standard equipment for artificial ventilation until the 1960s. And again, importantly, you know, if you think of those Collins tank respirators, the airways was still unprotected with that device. And then finally, in 1958, Drs. Gordon and Saffer demonstrated the superiority of mouth-to-mouth ventilation to manual techniques. And this freed the rescuer's hands to maintain airway patency. The rescuer was then able to incorporate head extension and mandibular advancement while applying ventilation and keeping that airway patent. Well, there were a lot of 20th century advances. In 1913, Jackson designed a laryngoscope with electric cords from a large dry battery. In the 1920s, McGill designed that U-shaped laryngoscope that had self-contained handle batteries. In 1928, Flagg designed a rigid L-shaped laryngoscope, and it wasn't until the 1940s that we had folding laryngoscopes. Imagine, 100 years after the introduction of surgical anesthesia, we finally have a folding laryngoscope. As you know, Miller designed a long, narrow blade, and McIntosh in 43 developed that curved McIntosh blade, and then in 46, Miller developed a very fine, light, thinner, folding pediatric laryngoscope. We were also blessed with new anesthetic drugs at that time. Thiopental, introduced in the mid-30s, curare, thanks to Wright in 1942, and then succinylcholine around 1950. Of course, all of these drugs helped with intravenous induction and intubation. Ralph Waters, wonderful person, wonderful American anesthetist, had many, many accomplishments. He, as you know, designed a to and fro carbon dioxide absorbent system, although he eventually favored closed circuit circle system. But perhaps he had many, many contributions to our specialty. But perhaps his greatest contribution was establishing an academic anesthesia department in Madison, Wisconsin. He was responsible for training some of the preeminent anesthesiologists of the mid-20th century. And during that time, over the course of the introduction of surgical anesthesia to well into the 1900s, we saw a progression of anesthesia delivery systems, starting with that open system with gauze-covered wireframe mask, and then we had inhalers, which were cumbersome and they were imprecise, and they were by and large abandoned after World War I. And then finally we had closed and semi-closed anesthesia circuits. Enter Arthur Goodell. He was a very talented individual who accomplished a great deal. He grew up in grinding poverty, but he became quite adept at overcoming adversity. He had some traumatic finger amputations, but became a musician. He unfortunately developed insomnia and addiction. He had trouble sleeping, so he took barbiturates to help him get to sleep. And then he had trouble waking up, and he took amphetamines to help him wake up. But he was able to overcome his addiction, and he was very straightforward about his difficulties and took great pains to try to educate other people from the potential pitfalls of self-medication. In the late 1920s, he created the first inflatable cuffs for endotracheal tubes, and he created these from the fingers of rubber gloves. He designed in 1933 a molded rubber airway with a metal insert to prevent occlusion. So it was softer than those early metal oral airways, but it did have inserted inside a metal one that could prevent occlusion. And Airway adventures. Airway was his dog. And we see here, poor Airway. Fortunately, he was anesthetized first with a cuffed endotracheal tube and inserted into this tank. And this was a demonstration so that at the end of Airway's immersion, Goodell took him out of the tank, extubated him. Airway woke up very rapidly. He shook himself off, as only doggies can do. According to documented evidence, Airway saluted a post in the auditorium and then marched briskly away to the applause of all present. Now, Noel Gillespie wrote in 1941 from the University of Wisconsin Press, another wonderful colleague of Ralph Waters. The merits of endotracheal anesthesia stand established at the present time. Unfortunately, any attempt to evaluate its demerits is frustrated by the paucity of recorded fact as to its complications. The habit of keeping accurate records of clinical experiences is still too rare among anesthetists. So documentation wasn't quite what it should be at that time. And then Stuart Cullen, 100 years after the introduction of surgical anesthesia, commented, "It is a conservative estimate that 90% of the deaths occurring under anesthesia are due to improper management of the airway." There were, of course, other causes, such as inaccurate delivery systems and polypharmacy. Acceptance of cyanosis is normal. But airway patency was not the number one killer, an obstructed airway. And we have here Francis John Murray, another Irish American who contributed to developing new endotracheal tubes. He developed a tube that was compression resistant, easily sterilized, and came in a sufficient range of sizes. And of course, his Murphy swizzle tip was in contrast to McGill's straight bevel tip. And of course, we're all familiar with the Murphy eye in endotracheal tubes. Well, what were the confluence of factors that enabled the advancement of endotracheal intubation for anesthesia? Obviously, development of laryngoscopes and endotracheal tubes, critical thinking about the limitations of mass ventilation, introduction of muscle relaxants, and again, war. World War II injuries mandated use of endotracheal intubation by trained anesthetists in order to avoid respiratory compromise, aspiration pneumonia, respiratory failure from pneumothorax, etc. And so gradually we had an evolution of the technique from a primitive hazardous procedure to a routine one that continues today. There were, of course, other helpful advances, gradual improvements, as we mentioned, in developing muscle relaxants that had fewer hemodynamic side effects, development of fiber optics. And then in the early 1980s, Archie Brain, whose mother was Irish, developed an LMA. And this completed a cycle. We go now from glottic, infraglottic, back up to supraglottic airways again. And it's really wonderful to think of the number of lives that a Brain's device has saved. It was really an inflection point in safety and airway management. We've tried to stress the role of serendipity, Macintosh's friendship with Alfred Morris, development of the Macintosh blade by his technician Richard Salt, and McGill and Macintosh became anesthetists by chance, and then blind nasotracheal intubation by McGill and Robotham. So we see that how fortuitous observation is, and as Marcel Proust said, the real voyage of discovery consists not in seeking new landscapes, but in having new eyes. And speaking of eyes, Alexander Solzhenitsyn, a non-Irish winner of the Nobel Prize in Literature, said, "Dwell on the past and you'll lose an eye. Forget the past and you'll lose both eyes." And finally, I'd be remiss if I didn't acknowledge the invaluable assistance of Karen Biederman, director of the Wood Library Museum of Anesthesiology, and her dedicated staff, and so generously providing me with the photographs that were used in this lecture. And I'd also like to thank my husband, Dr. Jonathan Martirosian, himself an ophthalmologist, who has to put up with me on a daily basis. Thank you for lending me an ear. That was to resuscitate drowning victims. They thought that tickling the patient was very important to a successful resuscitation, that it had much more preeminence than maintaining a patent airway. Go figure. I wasn't around then. Close, but not quite then.